All right, it is 6 p.m. and we shall begin our program for the evening. Thank you all for joining us. We had over 80 people register for this event, and I'm looking forward to everyone joining us. My name is Selina Osei, and I am the president for NAHSE Connecticut. I want to begin with a few housekeeping rules and let you all know that this webinar is being recorded. So at this point, if you do not wish to be recorded, you can choose to turn off your camera. All participants are placed on mute upon entry. Please, if you want to, you can have your camera on as much as possible. We do have allotted time for question and answers at the end of the presentations. However, if as our esteemed guest presenters are presenting, the questions pop up, feel free to drop them in the chat and we will make sure that they are aware of these questions. Welcome. Again, my name is Selina Osei. I am the current president for NAHSE Connecticut. Tonight's event will be moderated by our executive director, Dr. Lisa Mallory, and we have joining us Dr. Camilla Lawrence and Dr. Kristen Zarfos, who will be each giving us presentations about different aspects of breast healthcare, health disparities, the state of breast health in Connecticut, and Afrocentric and gender-affirming approaches to breast health care. To close out this event, I'll be coming back to wrap up the event with a few evaluation questions and how to get your credits for ACHE and master chess or chess credits. Okay. So a little bit about NAHSE. For those of you who are hearing of us for the first time, the National Association of Health Services Executives is a nonprofit association of Black health care executives founded in 1968 for the purpose of promoting the advancement and development of Black healthcare leaders and elevating the quality of healthcare services rendered to minority and underserved communities. And we are very delighted that for this event, we have our very first executive director for the organization who joined us in August of 2021, joining us to serve as the moderator for the event. Dr. Mallory, thank you so much for joining us, and I'll hand over to you.
Thank you so much, and good evening to everyone, and welcome to this very important event. I'm delighted to be participating today in this important, in this important session. And I want to recognize our Connecticut chapter for their leadership and for addressing this very important topic. Again, as Selena said, if you have questions, please place them in the chat. We're going to try to get to as many questions as we can, but in the interest of time, I'm going to go through them and try to see what we can address as quickly as possible. And many of your questions will be addressed in the wonderful presentations these wonderful dynamic women have put together. You have their bios in front of you, but I'm going to take the liberty of sharing a little bit more about them both. I'm going to start with Dr. Camilla Lawrence. She's a surgeon and a leader, and she finds herself in a special place in her career where she's balancing patient care and the growth of the organization through strategic planning, partnerships, and execution. And over the past few years, her team has delivered significant improvements in the patient experience by creating a model that has been replicated in the Hartford healthcare system. After success as a science and health teacher in New York City, she made the life-changing decision to enter medical school in a training and career path that included residencies at Westchester Medical Center in New York and a breast surgical oncology fellowship at the John Wayne Cancer Institute in Santa Monica, California. She prepared to save and improve lives. She wanted to be the best breast surgeon she could be. And she is certainly proving that to be true. During her tenure with Hartford Healthcare, she has had the opportunity to change the way they treat patients while also serving as an active presence in her community through diverse board memberships and numerous charity events. We also have the wonderful pleasure of having Dr. Kristen Zarfos joining us, and she is a senior attending breast surgeon and medical director of the Carl Krapek Comprehensive Women's Health Center at St. Francis Hospital in Hartford, Connecticut. She is a clinical associate professor of surgery at the University of Connecticut School of Medicine and a fellow of the American College of Surgeons. She's an advocate of women's health in the public arena. And I wanted to point out to all of you that in 1997, she was recognized at the State of the Union address by President Clinton for her advocacy for women with breast cancer who were being denied hospitalization after undergoing the loss of their breast for cancer treatment. Her work with Congresswoman Rosa DeLauro and an amazing national grassroots movement of over 10 million women led to the passage of a law in the US Congress's House of Representatives by an overwhelming majority protecting women with breast cancer from denial of care. Presently, in addition to practicing healthcare and cancer care, breast health and cancer care, she is recognized for her strong interest in women's comprehensive health, delivering evidence-based talks to the public, like sessions that NAHSE is having today, and to healthcare professionals, not only on breast health and breast cancer, but also on specific aspects of women's overall health, with the goal of empowering women with the facts about how to improve and maximize their health. So we have two wonderful women joining us today, and we have a very important presentation that is going to be shared. But the first thing we want to do is we're going to have a poll of all of our participants. You'll see several questions here that are going to be asked on the screen. And we're going to ask you to respond to those questions. I think we have a few more seconds left if you can give your answers. Okay, I think we have 100% participation, at least those of you that are participating. So you can see the results here. Within the state of Connecticut, uninsured and underinsured individuals can receive breast cancer screening services for free. And the majority of you answered true. Exposure to feminizing hormones does not increase your risk of breast cancer. And the majority, 73%, actually opined false, which is also true. So with that, we're going to start with Dr. Lawrence and her presentation. And after that, we'll engage in questions. Again, if you haven't asked your questions already, please put them in the chat and we'll try to address as many as we can. Thank you.
Okay. Can you hear me? Good evening, everyone. Thank you very much for joining us this evening to speak about a topic that's near and dear to our hearts. I want to thank Dr. Mallory, as well as my colleague, Dr. Zarfis, for the opportunity to work collaboratively in presenting, and also to recognize Selena, who's been the engineer behind us all coming together for this event. So I'm charged with speaking with you this evening regarding the status of breast cancer within the state of Connecticut. In particular, I want to focus on access, barrier, as well as the role for advocacy. I would like to begin by really acknowledging my colleagues at the Department of Public Health. I must give them credit. I volunteer with the Department of Public Health in the state of Connecticut, and most of the data being shared here was collated by those staff members. So cancer remains the second leading cause of death within our state, only after heart disease. And in 2021, we can move to the next slide. In 2021 alone, and we had an upwards of 23,000 new cancer cases within our state that resulted in about 6,400 deaths. So roughly about a third of our population who were diagnosed with cancer died of their disease. Next slide. The good news is that 7 in 10 diagnosed are still living with cancer. So 70% of those that were diagnosed with their cancer are alive and well. However, I think the 3 in 10 represents additional work and opportunity for us to decrease mortality rates from cancer within our state. Next slide. Nearly 12% of Connecticut residents will be impacted by a form of cancer at some point throughout their life. The most common is skin cancer, coming in about representing about 26% of cancer cases. I think we all know somebody who's been diagnosed with skin cancer. Second most commonly diagnosed cancer within our state is breast cancer, representing 17% of all cases. Next slide. I'm not asking you to read all of this slide, but the message here is that in 2017 alone, 466 women died of breast cancer. We had about 3,236 that were diagnosed. So imagine you're sitting at a coffee table with 8 of your girlfriends. One of you will be diagnosed with breast cancer during your lifetime. Breast cancer is the second leading cause of cancer death in Connecticut women, and is the most common cancer, accounted for about 31% of all new cancer cases within our states. Next slide. The mortality rate for each group is highlighted here, and you can see that non-Hispanic Black women have the highest mortality rate, representing about 21.9 deaths per 100,000. The mortality rate is higher among Black women, which I think my colleague, Dr. Zarfas, will go into detail about. But I think it's also important to celebrate that our mortality rate has been decreasing between 1990 and 2017. The breast cancer mortality rate among Connecticut women continue to decrease, on average about 3% per year. This is data from the Department of Public Health in Connecticut, and I want you to focus primarily on the numbers. So about 9,769 primary breast cancer cases were diagnosed in women between 2016 and 2018. And of those, 816 were diagnosed in non-Hispanic Black women. But let's take a look at the mortality, which is the second graph here on your left. And what you'll notice is that we had 1,336 deaths from breast cancer in Connecticut women between 2017 and 2019. Women of color, Black women, take a look at our mortality. It was the highest, coming in at 23.9. And this is based on age-adjusted mortality. So still significantly higher than we would like it to be. So there's a lot of work to be done within the Black community to help to mitigate or decrease the mortality rate that we currently experience within our state. There are 4 molecular subtypes of breast cancer. And what I want you to take away from this slide is that you have the luminal A, B, HER2 positive, and triple negative. And I bring to light triple negative breast cancer because this cancer has a poor prognosis. It's more common in younger women, in particular women of color. And this is also evident within Connecticut, within our data set. It's a more aggressive tumor biology more often than not, and has an increased risk of recurrence as well as distant disease. So within the state of Connecticut, if you take a look for Black women, almost twice as likely as it is for white women, and a slightly elevated for Hispanic women. Let's talk a little bit about access, because this plays a very important role in terms of our ability to diagnose and treat breast cancer. The Healthy People 2030 identified access to healthcare as one of the critical social determinants in health. I mean, the ability to access quality care in a timely fashion is directly related to mortality. And we all know that the health equity can only be achieved when every person is able to live their healthiest life, even in communities that may have higher burdens of cancer. So early detection of breast cancer is paramount, and it decreases mortality. However, within our state, our mammography screening rates are still less than ideal. It's important to remember that the diagnosis of breast cancer is not a death sentence. Breast cancer, when caught early, is a very treatable disease. I often have patients anecdotally who would say, well, I do my own self-breast exam. I haven't felt any lump or any changes within the breast. And I'd just like to remind the audience this evening that breast cancer in some cases do not present as a visible abnormality. It may be something as simple as microcalcifications that are only going to be identified by getting a mammogram done. So not all breast cancers are palpable or can be visibly seen. There are no shortage of screening sites within our state. We can move ahead back one slide. The Kaiser Family Foundation Health Data Facts provides us with information for women ages 40 and older who reported having mammogram within the prior 2 years. And if you take a look, this is the data from 2021, and you notice Connecticut, we ranked at about 78%. So not too bad. We're above the national average, which is about 72%. However, the state rate was lower than the national average for non-Hispanic Black women. So that was 74% versus 78%. So still some work to do. Ideally, what we would like is for us to have close to 100% screening among all subgroups within our state. Next slide, please. Now, barriers to treatment. While most commercial insurance, as well as Medicaid and Medicare and various need-based program provides coverage for screening mammography, financial as well as cultural issues are also important hindrance to breast cancer screening among African-American women. And both are modifiable risk factors. And it's very important for us to spend time to address these modifiable risk factors in order to increase utilization of screening mammography among women of color. This is why it's important. And I mentioned this before, is that African-American women, we are almost twice as likely to die of our disease when diagnosed with breast cancer. So the difference is it's about 41% to be exact, higher mortality rate. Next slide, please. The stage of diagnosis is absolutely critical. And I included this slide in the presentation because I wanted to really walk through it because I think this is perhaps the most important slide that I have here for you. If you take a look at local disease, this is a 5-year survival for breast cancer based on stage. So early stage is also considered local. So this is diseases confined to the breast. Look at the survival rate. It's about 98%. In women who have regional disease, so this is disease that's within the breast and may have made its way to the lymph node in the armpit, the survival rate at 5 years is 84%. But take a look at distant disease. These are women who are presenting with later stage disease. This is disease that is no longer confined to the breast. It's made its way to the lymph node and can be found in other organs. And it dropped precipitously to 24%. So only 1 in 4 women survive at 5 years who are diagnosed with metastatic disease. So you can see the importance of regular and consistent screening. So the message that's screaming at us this evening is that screening mammography is imperative. We really need to encourage our communities to get screening mammography because it's a game changer and it makes a huge difference. Next slide, please. So early detection, the big take-home message, early detection of cancer saved lives and it improved health outcomes. Next slide, please. So the question that was posed earlier was regarding the availability of screening mammography as well as detection and treatment of breast cancer in the uninsured or underinsured. And luckily, within our state, within the state of Connecticut, we have the Connecticut Breast and Cervical Cancer Early Detection Program. This program promotes screening, detection, and treatment of cancer in the unserved or underserved or uninsured population. There are some eligibility requirements that are primarily economically related, but some of it I want to point out and put in bold here has to do with high deductible. And I wanted to bring this to the forefront because what I've noticed in my practice is that it's not uncommon to encounter patients who are professional women, perhaps making a salary between $60,000 to $100,000. They are fully insured, but guess what? They have a high deductible plan. And they have an imaging study, whether it's a mammogram or ultrasound, and they then need diagnostic studies, or they may need a biopsy to clinch the diagnosis. And you have to meet your deductible before the insurance will cover your treatment. And I can't tell you how often I have women who will defer on proceeding with the diagnostic imaging or perhaps the breast ultrasound if their mammography is limited by the density of the breast, or if they need a biopsy. And the primary cause is usually, or what's referenced or told to me is usually, I have a high deductible insurance, I don't have $2,000 or $3,000 to pay right now. As part of my deductible, I'll come back in 6 months, or it's delayed. And we know that we cannot afford delay in treatment. And so the majority of time I try to refer these patients as well to the Connecticut Breast and Cervical Cancer Detection Program to see if they're candidates for the program, so that they can actually get the screening study that is being recommended, as well as the biopsy if warranted. This is by no means an exhaustive list, but there are additional organizations that provides early breast cancer detection outreach, either directly or by funding other programs. For example, throughout Hartford Healthcare or different hospitals, we have various grants that are put together by donors that helps to offset the cost of screening, diagnostic, as well as biopsies, breast biopsies for our patients. The American Cancer Society is another example. Breast Cancer Alliance, which is a Greenwich-based nonprofit, also provides grants that help to meet the needs of the uninsured or underinsured within our state. Connecticut Breast Health Initiative has been a big proponent of supporting breast cancer early education, as well as research within the state. And there are several others that I won't list all, I haven't listed all of them here. I want to wrap up by talking about advocacy. So what can you and I do to move the needle towards increasing mammography, which will result in early detection and treatment of breast cancer, as well as to push the needle for equitable outcome for those impacted by this disease? Next slide, please. I want to start by just telling you a story. I love storytelling. So before 1998, there was no federal legislation requiring health insurance carriers to cover reconstructive surgery. There was a young woman on Long Island. Her name was Janet Franquette, and she was diagnosed with an aggressive form of breast cancer in 1997. She needed a mastectomy after chemotherapy to shrink her tumor, and she desired breast reconstruction to restore the breast. Upon contacting her insurance carrier, her reconstructive surgeon, Dr. Todd Whiter, learned that the insurance plan had refused to cover the reconstructive surgery. It was considered cosmetic, and he was told to plan to use a skin graft. Luckily for the patient, the physician went ahead and performed the surgery free, but he was rightfully outraged by the carrier's decision, and he decided to launch a crusade to change this by recruiting the help of several politicians. And that's where the Women's Health and Cancer Rights Act of 1978 came about, which is a federal law that now provides protections for patients who have breast mastectomy so that they can have breast reconstruction. Most recently in 2021, Representative Hastin also planted a bill in the House which will help to cover nipple areola tattooing. So the insurance carriers will be asked to cover. So this is all part of the reconstruction process. Within our state alone, I will tell you that there is currently a bill in the House which was presented last week actually, and it's a bill concerning required health insurance coverage for breast health benefits. And this is very important. We're talking about expanding the coverage so that there's no burdensome out-of-pocket costs for screening, as well as diagnostic mammogram and breast ultrasound, as well as MRI. And I think this will be a huge game changer because, as I mentioned before, those high deductible plans, most women are foregoing the additional diagnostic workup that's needed because of these high deductible plans. Next slide. Just last week, President Biden signed the fiscal year 2022 budget into law, and there were several provisions made to allocate resources to improve in screening, diagnostic, and treatment services for breast and cervical cancer. In particular, the NIH received over $45 billion, and about $6.7 billion is going to the NIH. And one of the things that I really liked about this was that the NCI now must provide Congress within a year updates and activities as it pertains to metastatic breast cancer, including progress made with respect to health equity in clinical trials. As you know, Black women are underrepresented in many of the clinical trials that have been done and are ongoing. Next slide. So what can you and I do to support the fight against breast cancer as well as survivors? You can see that by advocating for policy change, it does make a real difference. Address inequities in your communities by speaking up, raise awareness about healthy lifestyle. It's so important to vote. Contact your elected official about cancer-related issues. Support funding if you're in a position to support funding for programs and policies that reduce exposure to risk. And educate sometimes maybe our own employers as to how their own policies and system and work environment can be improved to reduce the burden of cancer care. And I'll wrap up there and allow Kristen, Dr. Zarfas, to present. The major takeaway points here for you this evening is really efforts to promote primary prevention, early detection, treatment, and quality of life for those living with cancer have never mattered more than ever. And promoting equitable access to resources like quality and affordable screening, treatment, and care options are vital. It's important that we cultivate, train, and maintain culturally competent workforce. And that doesn't just include physicians. We're talking about nurses, patient navigators, community health workers. That's how we're going to address this problem of inequity. And everyone can be an advocate. I think any sort of advocacy around breast cancer, diagnosis and treatment, it's really, truly a bipartisan issue. And we all must do everything that we can to reduce the mortality from breast cancer until, of course, we are able to identify a cure. So thank you very much for your time. And Kristen, I'll transition to you.
Thank you. What a great presentation.
Oh.
And I really appreciate you mentioning the bill that's before the legislature that came up last week to eliminate deductibles. Great. Well, thank you for this opportunity to work with Dr. Lawrence. I want you in the audience to reflect on your successful careers. And I would surmise that not only your rich education, but what you've learned from individuals and experiences that you've have contributed also greatly to each new assignment or task you take on. And I would say Dr. Lawrence and I do the same thing. We learn from each patient. So that we can take care of other patients even better. And we also observe patterns in the patients that we take care of. Then we go to the science and the research to say, are these real patterns or just anecdotal observations? And so that's what I did, working in downtown Hartford, taking care of women with breast cancer. I noticed some patterns, just as Dr. Lawrence mentioned, breast cancer, more aggressive breast cancer with the triple negative type cancers. And in addition, my observation that was breast cancer was occurring in younger Black women than what I seem to observe in white women. So I went to the science, looked at the data, and tonight I share with you what I learned. And so it's about racial inequities in breast cancer in Black women in America. Next slide. Important that you know that there's an indifference to the age of onset and of breast cancer in young Black women. And young Black women are dying unnecessary preventable deaths from breast cancer and have been for 2 decades. The first time it was noted in a major publication, Cancer, was in 2002. And yet here we are today with screening mammography, which Dr. Lawrence has said, and I echo, saves lives. A key fact is the population-based breast cancer mortality is 40% higher among African-American women compared to white women. Next slide. There are 2 factors that contribute to this disparity. One is a delay in finding breast cancers in Black women because they occur in women at a much younger age. We're going to get into the details of screening recommendations in this country and the age of onset for breast cancer in young Black women. And the second characteristic that Dr. Lawrence touched on was this aggressive triple negative type breast cancer that occurs twice as often in Black women. Next slide. 33% of Black women develop breast cancer before the age of 50, compared to 20% of white women. And so because of lack of screening, by the time breast cancer is found in Black women, it's already advanced and spread beyond the breast. And 49% of Black women, that's half of Black women, have regional or distant disease. If you looked at that pie chart that Dr. Lawrence had, which is a great pie chart. Next slide. So to decrease this 49% of Black women from being diagnosed with advanced breast cancers, we have two tasks. We have two assignments, compelling assignments. We need to find the cancers at an earlier stage by providing access to screening mammography at an earlier age-appropriate age. And number two, understand triple negative breast cancers. Next slide. Now, breast cancer treatment has two strategies. One is local treatment. In other words, what surgery is needed to remove the cancer. But equally important, or even as a surgeon, I would say more important, is what treatment to give. And that's called systemic treatment that circulates in the body to eradicate any cells that may have escaped beyond the breast. To treat cancer cells beyond the breast, scientists research to find medications that can target breast cells based on receptors. And so when we talk about triple negative tumors, those are tumors that have no receptors or targets on the surface of the cells. Next slide. Now, what is a triple negative breast cancer? So many breast cancer cells have 1, 2, or even 3 of these important receptors on the surface. And these receptors are important targets for chemotherapy, oral or traditional chemotherapy, to block hormone attachment and block the growth of abnormal cells. Doctors take a biopsy, a piece of the tissue, and analyze it. And in triple negative breast cancer, none of the 3 important receptors are found on the cell surface. And that makes it difficult to use traditional treatments to target the cells. Now, to give systemic therapy, cancer cells are more vulnerable when they have these targets on the surface. And by identifying and engaging and destroying the cancer cells, the therapy is more effective. So you can understand if they're triple negative or no targets on the cells or no receptors, systemic therapy is less focused and less effective. Next slide. In triple negative breast cancer, there are no receptor targets, and with no receptors to block, the message to stop the cells growing is not transmitted, and thus there'll be continued growth. And that's in a nutshell what triple negative cancer cells are. And as we said earlier, both Dr. Lawrence and I said, it's a higher proportion of these type of cancers in Black women. Next slide. Now, until recently, there was a quandary because if there are no targets, how can we treat the tumors? And I'm happy to say this article published in the New England Journal in February 10th, 2022, in fact, if you want to look it up, it shows great success with this drug that can target triple negative cells, even though there are no targets on the surface. So there is hope, but we want to find these cancers before they have spread and before cells have broken off, and that'll get us back to early detection. So yes, there is hope, great research, and all that money that Dr. Lawrence talked about that's gone to the NIH is going to help expand the knowledge we have on these types of cancers. Next slide. Now, returning to finding breast cancers in an early stage. If we can find breast cancers before spreading beyond the breast, it decreases death from breast cancer, regardless of ethnicity or type of cancer. Actually, since the 1990s, when we started doing mammography regularly, there's been a 40% decrease in breast cancer mortality due to access, just as Dr. Lawrence said, access to screening mammograms. Next slide. Yet, young Black women are denied access to life-saving screening mammography at the age that they develop breast cancer. Remember, 33% of women develop breast cancer before the age of 50. And this is because of age-restrictive national guidelines that ignore the younger onset of breast cancer in Black women. Next slide. these are the guidelines. The US Preventive Task Force guidelines start mammograms at 50 to 74. Aha, you'll say, second bullet says 40 to 49. Decision to start screening should be an individual one based on risk. But physicians, and Dr. Lawrence pointed this out on one of her slides, if physicians don't know that breast cancer develops younger in Black women, then they're not making the recommendations. And if women don't know, they can't advocate for themselves. The American Cancer Society recommendations are age 40 to 44, and they're moving towards a baseline of 45 to 50. And again, my 32-year-old son tells me I repeat myself too much, but I cannot repeat this so much. I cannot say it enough that women, 33% of Black women are being ignored. Next slide. Now, 3 times more young Black women die from preventable breast cancer death. Next slide. This discrimination is recognized by physicians from all across America who've made a call to action to revise these racially inequitable guidelines for access to screening mammography. Next slide. Physicians from across the United States, and these are published scientific articles from, you can see these are major institutions across our country, physicians who feel the same way that I do and Dr. Lawrence does about early detection. Next slide. And the most recent articles are this one published, Lisa Newman is an outstanding breast surgeon, originally at Henry Ford, now at Weill Cornell, that shows that screening mammography can mitigate the breast cancer disparities through early detection, even in the more aggressive cancers. Next slide. And then this article out of University of Pennsylvania this year says it better than anything I can say. Racial disparities persist in cancer screening. The US Preventive Task Force colorectal screening guidelines illuminate inadequate breast cancer screening guidelines for Black women. So what does this mean? Well, the US Preventive Task Force puts out guidelines, as I showed in the earlier slide, for screening of different cancers. And recently, the age of screening for colorectal cancer, which had been 50 years old, dropped to 45 because they had observed the patterns of onset. They make screening now for colon cancer age appropriate. But this isn't the only precedent we have, because young Black men develop prostate cancer younger than white men. PSA screening for prostate cancer, is covered at a younger age for Black men compared to white men, a precedent. So why not for young Black women? And women of Jewish Ashkenazic descent, we observe the pattern that they have a higher incidence of having gene mutations in the BRCA genes, BRCA genes, and therefore they have a more open coverage for genetic testing and screening than other populations. This is called risk assessment, and we all do risk assessment. You in the audience know that people who have hypertension need to be careful about their salt intake. We know that people with diabetes need to be careful about their toes and their eyes. They're at risk. It's risk assessment for different populations. We also know, and I hope all of you in the audience, women and men, if there's a family history of heart disease in your family, that women identify that if there's been young women in their family and their heritage of the heart disease, they are at increased risk and should be empowered with those facts. So what University of Pennsylvania is saying is a US Preventive Task Force, US Preventive Services Task Force, has recognized the age population for colorectal cancer. Why not do it for young Black women? Next slide. Now, why am I so passionate about this? And why is Dr. Lawrence so articulate and passionate in the slide she presented? It's because for us, it's a real fact. It's not theoretical, but it's tangible, because both of us have seen patients who, when we actually are operating and our hands can feel the cancers in the breasts or in those lymph nodes, women who we know at that moment when we touch those cells, touch those hard lymph nodes with cancer cells in, We know that perhaps if they had had a mammogram 2 or 3 years earlier, that they would not be at that stage of cancer. And Dr. Lawrence pointed out how important stage is. So what can we do in the medical community? We need to find these cancers at an earlier stage before they've spread. We need to reduce the disparity in the death rate for breast cancer for young Black women compared to white women. And doing nothing means a 3-fold chance of death for young Black women. And I would here just quote Archbishop Desmond Tutu when he said, if you are neutral in situations of injustice, you have chosen the side of the oppressor. And young Black women don't need to die unnecessarily. Next slide. So we ask for your advocacy support for access and coverage to age-appropriate screening mammograms to save the lives of vital young women in the most critical time of their life. When is more important than in your 30s and 40s? When you're in your career or still in your education, or you're raising children, or you're taking care of your elderly aunts or parents or grandparents. I am well beyond that decade of my life, but it is a very important time. And these women are too important to cast our eyes aside. And we're not asking for anything different other than the precedent of what's been done for prostate cancer, BRCA testing, colon cancer. Next slide. What can we be done as advocates in America? And I had not seen Dr. Lawrence's slides, but I'm so glad you talked about advocacy. We need to change the current mammogram guidelines. We need to appeal to the U.S. Preventive Services Task Force and the American Cancer Society. But we need a massive national education program to providers, those who are seeing women, those who will say, this is a young woman with breast cancer, a young woman who has a family history of breast cancer, although Dr. Lawrence and I know 70% of women with breast cancer have no family history. And so if you're young and there's an abnormality in the breast, we cannot turn deaf ears on it. And we are empowered not only to have sensitive practitioners in the community, racially sensitive practitioners, but also we need to educate the doctors, the nurses, the advanced practice nurses, the physician's assistants. Next slide. And outreach to women. We need to empower women with the facts. So there are 2 stories I can tell you, and I only have a few minutes, so let me just tell you these stories. June 6th, 2021, I was watching the NewsHour, and they did a wonderful show on a woman named Regina Hampton, who's a breast surgeon in DC. And during this presentation on a mobile unit for mammography, they interviewed a 32-year-old woman, and she said it far better than I can ever say it. I didn't know I could develop breast cancer this young. And she said, my physician told me when I presented with a lump that, quote, I was too young to have breast cancer. She subsequently had bilateral mastectomies and chemotherapy. And more recently, August 27th, 2021, on Connecticut Public Radio, a young woman from New Haven was interviewed and had had the same experience. 2 years in a row, she asked for a mammogram, and she had a mother and grandmother both with breast cancer, and her doctor denied her ordering it, and she ultimately had breast cancer. So we have to empower women. And if their physicians don't know, we really need to empower women to say, these are the facts. I would like to have a mammogram. Next slide. You, as very powerful women and men, part of this organization, have the ability to do that. You can help set the standards and not only educate women about mammography, but prevention and lifestyle strategies that can decrease a woman's chance of developing breast cancer of all ages and all ethnicities. It's a time that we need to empower women with the facts. Next slide. Knowledge is power, Francis Bacon. He didn't know about mammograms, but your voice, empowered with knowledge, is an unstoppable force for change to save very important lives. Next slide. I'm going to stop here. There's an appendix. I think these slides will be available. And so they're references for all the facts I presented here today. I didn't want to encumber the slides, so you can use the appendix. And I thank you for your attention. And I thank Dr. Lawrence for working together tonight.
Thank you, Kristen. That was wonderful.
Wow, that, I have, that's, just so many questions that I have myself. And so I want to remind those of you that are participating, to go into the chat and let us know what questions you have. We've already received some questions, and I'm going to try to go through them as quickly as possible. And let me start with a quick one, and I'll throw this out to either one of you, Dr. Zarfos or Dr. Lawrence. Fact or myth, high rates of breast cancer in Black women are associated with those of a history of long use of chemically treated hair, or actually, straightening hair. Is that a myth or is that a fact?
I think the verdict is still out, Dr. Mallory. Last year, I think it was a study out of North Carolina, suggested that there was an increased risk and incident of breast cancer among women. It was primarily referring to those who use permanent hair dye as well as a chemical straightening of the hair. I think the evidence is still inconclusive. We need additional research to really make that determination, but there's really no identifiable cause at this point. Is there potential that it could be increasing your risk? The thought process is that it may be interfering with our hormone production, and we know that the majority of breast cancer that we see are hormone receptor positive, the luminal A type breast cancer, but I don't think the data is yet conclusive for us to make that definitive recommendation.
Thank you for that. I wish that the movement towards natural hair was founded in, that potential risk, but unfortunately it's not. But nonetheless, education is clearly important. Dr. Zarfos, let me ask you this question about how can providers transform the care experience of transgender individuals in a safe, gender-affirming way?
Well, I think that the saddest thing that occurs that transgender people know that they know more about what should be done for their health than physicians. So I think education is really key. I provided some slides that will also be available for the audience, but what we need to do is be present. First of all, we need to be educated. We need to understand, and not just breast surgeons, but primary care physicians, APRNs, PAs, what is transpiring. And we need to be open and receptive to people. Many years ago, there were physicians in Connecticut who would help people who wanted to transition go to Ohio and have surgery, and those patients would come back here and for me to take their stitches out or take care of them post-operatively. And, I was so touched by how frightened they were when they walked in my office, thinking that people were going to be judgmental. And I think the key is just being present, just accepting people for who they are. That's one piece of it. But the other piece is we need to recognize what strategies need to be done to screen still for breast cancer, even after someone's transitioned and had their breast removed, or transitioned and didn't have their breast removed, or are taking hormones. And so I've supplied some slides that can be available for the audience. But I think it's really about acceptance for people as who they are, and just take care of them.
Thank you for that. Thank you. And thank you for those slides and additional resources. Dr. Lawrence, when it comes to breast health care, a lot of awareness is raised around breast cancer issues. Are there other prevalent breast diseases among Black women we should be aware of?
The other thing that comes to mind, Dr. Mallory, is actually macromastia. You see it very commonly among Black women, and that's referring to the enlargement of the breast, which can result in a lot of functional issues such as shoulder pain, back pain. It can be debilitating for some women. Those are patients who usually present to my practice. I usually work them up, ensure that there aren't any underlying malignancy or breast problems, and they're appropriately referred to plastic surgery for them to be considered for breast reduction, which I will tell you, I've had testimonials that has significantly improved their quality of life after having the surgery. There aren't any other disease per se that I can think of, except for maybe phylloides tumor, which is sort of like a sarcoma of the breast. But the big one, which is the one we harp on a lot, is breast cancer.
Let me ask you, I'm just wondering, and I'm not sure if we covered this, whether or not during the pandemic, when we were not receiving the, I went and got my physical today, hadn't been in 2 years, unfortunately. Don't do what I did. Are we also seeing that with the general population, that there was a decrease in screening based on the pandemic and people, kind of didn't go to get their usual mammograms and so on?
Absolutely, absolutely. We have seen that, and we're dealing with the ramifications of that. And I think we will be into the future, because there's still women who are a bit terrified to present for their screening studies, not just mammography, but their colonoscopy as well. And that has definitely impacted the stage at which their cancer will be diagnosed. So throughout the pandemic, we have been, as breast surgeons and different health institutions, have been strongly advocating to women that breast cancer has not stopped because of the pandemic. So we need to continue to do our due diligence by obtaining our screening mammogram.
So let me again remind those of you that are participating, if you want to actually come on screen and answer a question, you can lift your hand. We have about 5 to 6 minutes left, so we don't have a lot of time, but I will take this time up asking questions if I don't see a hand there or a question in the chat. Could either of you speak more to genetic testing? If a breast cancer survivor is still living, are there any recommendations towards those individuals around genetic testing?
Well, genetic testing has expanded. I think every 2 minutes, the criteria for testing changes, and that's a good thing, because when the national standards change, insurance companies have to follow through. And certainly now with triple negative, we know that patients should have genetic testing, and most insurance companies should cover that. And both where Dr. Lawrence works and I work, we have master's degree trained genetic counselors who can counsel patients. I think it's interesting that for many years, we just thought of the BRCA genes in terms of women of Ashkenazic descent or Jewish Ashkenazic descent, but we're seeing other patterns. We're seeing, and Lisa Newman, who I referred to earlier, the breast surgeon in New York, has studied patterns of genetic patterns in Africa, in different parts of Africa, and then in Black women, African American women in the United States. But I found it's interesting because in Hartford, we have a large Caribbean population. Women from the Bahamas have a higher incidence of BRCA positive cancers than from other places in the Caribbean. And the more we know these patterns, the more we can identify trends and be proactive in populations for strategies to prevent breast cancer and strategies of early detection. Camilla, what else can you add to that?
I think you've hit the nail on its head. I think it's important to have a conversation with your physician regarding your personal risk of breast cancer. And family history is king in this setting. So I usually tell patients, we know that, for example, if you're a carrier of the BRCA mutation, the current standard guidelines is that we begin surveillance as early as age 25. So it's very important to have those conversations. The genetic tests, the majority of which are now covered by our commercial as well as our Medicaid insurers. So do have that important conversation. If you do meet criteria, even if you've had your cancer and you're now a survivor, but you weren't tested before, you still meet criteria to be tested.
Thank you for that. I saw a hand by Darlene, and now she's gone. So I don't see her anymore, but she had a question that she was asking. So I'm going to continue quickly. How can medical schools better prepare future physicians on how to care for women of color, particularly Black women?
I think education, right? I really, really believe in education, as well as cultivating a culturally diverse group of clinicians. It's important for us to educate regarding the challenges for that particular subgroup. We have to know, as Kristen mentioned earlier, what are the risk factors for that? So when you, for example, you're dealing with a Black woman who comes in and she has a breast lump and she is 28 or she's 32 years old, it shouldn't be dismissed as a cyst. There should be a heightened sense of awareness that even though she's so young, within that subgroup, that she's at an exponentially higher risk of breast cancer, warrants an in-depth workup, which would include her ultrasound in addition to mammography and all the standard tests that you would utilize. So I think that's one. It's just increasing the pool of applicants, diversity, and cultural competence. I think you don't necessarily have to be a Black physician to deliver competent care. We can all be trained. I think appreciation of our own bias, knowing that we all have biases and how that can influence our decision plays a big role as well.
And I think that in training, although we all are forced to stick to a time template, the most important thing to develop trust is a 4-letter word called time. And giving time, teaching practitioners that sometimes you have to spend a little longer than whoever puts you on the assembly line, but there's nothing more valuable than sitting down to build trust. And regardless of ethnicity or male or female, to build trust requires time. And we need to teach our medical students that. We might get them in trouble, right, Dr. Lawrence, by teaching them not being on the time schedule that the bosses want. But at the end of the day, the time you spend with patients is precious.
And can you speak quickly about, on the other side, on the receiving side, the patient's side, the general anxieties and entrenched mistrust that many, including Black women, have of the healthcare system and undergoing surgery? How do we address those issues?
You know, I'm very open about it, and I make a genuine effort to address upfront what those fears are. Historically, if you look at our history, it is justifiable based on the scientific research that was conducted in the past on folks of color against their consent. So I have those courageous and honest conversation with patients, and I provide the evidence-based data, to support the surgical recommendation that they're being offered. I also attempt to explore not just cultural, but also religious biases or belief system that may influence a patient's decision. I have had patients who come in who are diagnosed with breast cancer and they tell me I'm going to go pray about it, or I have a meeting, coming up to meet with my pastor and we're going to pray on it. So it takes a lot of time, as Kristen pointed out, to position yourself, to listen, to understand, and then to be able to engage from a point of knowledge and humility, and to get them to really see and understand that you really have their best interest at hand.
I can't add anything to that. That's beautiful. That's beautiful.
Well, I want to thank you both. You certainly put in the time. You have the passion. You certainly have the a wealth of experience and knowledge, and your dedication. From NAHSE's perspective, whatever we can do to be advocates to push your agenda, our agenda nationally, I'm happy to do whatever I can to certainly support these efforts. You've given us some very concrete recommendations that we can all carry forward, and I hope that we will. This is being recorded and we will be disseminating it. And I really want to thank you both, Dr. Zarfos and Dr. Lawrence, for all that you've done and for partnering with us here at NAHSE. And we are here at your service, whatever we can do to partner with you, not just the Connecticut chapter, but all of us. Now I'm going to turn it back to Selena. Thank you all.
Thank you, Dr. Mallory. I am very grateful to all of you for joining us this evening. And I just want to quickly share that for those of you who joined for CHESS credits, you'll be receiving this deck so that you have information on how to access the survey and request your CHESS credits. If you're joining for qualified education credits, it is self-reporting, so you can go into your page, your My ACHE profile page, and report this event for qualified education credits. I am going to share a quick link in the chat so that you will all support our chapter with evaluations, and your feedback is very important to us as we continue to improve in our program planning. I want to especially thank CTAHE and Sophie, Connecticut, for helping advertise this program. There's a lot of you in this room that are joining from different parts of the country, and we appreciate their enthusiasm in partnering with us. Thank you all and have a great evening.